We're going to have a few minutes of remark by Dr. Moreno, who was a panel member of the first Vulnerable Patient Symposium, and we had discussion on this concept of risk factors versus risk markers. If Pedro remember, we were talking about what do we do for detection of hypertension. We know how many risk factors contribute to hypertension. Are we measuring endothelin? Are we measuring plasma renin activity? Are we measuring angiotensin in these patients? No, we're not. We're just measuring a simple cough-based marker of a systemic disease. Blood pressure is not the disease of the right arm. We have found a biomarker, an easy, inexpensive one, and I'm sure if you put that in the model, Dr. Taylor will tell you that model will be successfully cost-effective. We are looking for something like that for the bottom of our pyramid in order to cost-effectively start a screening, and that is the beginning. Pedro, I'd like for you to give us a few minutes of your comment.
We'll be very brief.
Go ahead.
Very impressed with the comments done tonight, and honestly, I'm not a cost-effectiveness person. I'm a clinician, and I do interventions. I'm focused on secondary prevention, which I'm more concerned about, actually, because the primary prevention, even though we have patients that occasionally are referred to us to do primary prevention, it's in the field of healthcare at a very bottom line, and probably not even physicians, general practitioners maybe. So I see this problem more on the education and sending the message for the traditional approach to good medicine initially. On the secondary prevention is a different story, and we already heard about it specifically with the cath lab techniques and all those. So to be honest with you, I still see the field a little bit confusing regarding the magic holy grail, test that will identify the patients that will end up with having an event.
No, I don't think that I can really talk of the cost effectiveness here, because what I do is I fantasize and I just dream and I sell dreams. We've been working on various nuclear strategies which try and identify the vulnerable plaque, and I believe that obviously the inflammatory markers, they do go a long way, the biomarkers go a long way, but eventually the identification of a vulnerable plaque is something which cannot be ruled out. And one really needs to look at a vulnerable plaque. And our belief is that one can really look at the macrophages in the plaque if we have these properly designed targeting strategies. We can look at the macrophages which are undergoing cell death, and once they are undergoing cell death, they are likely to make the plaque vulnerable, because it is likely that they release the metalloproteinases. So we can identify macrophages, we can identify the cell death or the apoptosis, and one can also non-invasively try and identify the release of metalloproteinases, which eventually could lead to the vulnerability of a plaque. Thank you.
Thank you. I'm going to have ask Dr. Berman to give a few minutes of comment, and then I'm going to go back to Dr. Shaw for a conclusion.
Well, thanks for the opportunity to say a few words. It's been a very interesting symposium. I completely endorse the concept of eradicating heart attacks. I think the Association for the Eradication of Heart Attacks is an excellent association for us all to become involved in. Looking at the evening, I agree with most of the speakers. I'm fortunate to be in a position of running a cardiac imaging section where we do EBCT, and we do nuclear testing, and we do PET, and we do CT, angio, and we do MRI. And in looking at that spectrum, my view of the pyramid coincides with much of what was said. I would I would point out that I think at the present time when we look at costs, that maybe we have to be careful about how far we stretch that lower limit of the intermediate risk group that might need testing. We noticed earlier Dr. Brownwald and Dr. Fuster both used a 0.5% per year limit, which is even lower than the 0.6% that Dr. Taylor's group had came up with, but it was reluctantly they came up with it because a 10 to 20% is something that would be more reasonable when we look at the proportion of the patients who would be tested and the risk of those patients. We're probably going to have to, in view of limited funds, be aware of that kind of limitation. But I think that starting with, in the intermediate risk group, an acceptance of the value of testing is a good starting place that our society hasn't yet reached. If you're in the Army, you might be able to get this test, but if you're not in the Army, you have to have $400 of spare change to be able to purchase the test because our third-party carriers, even in this clearly defined 10 to 20% risk group, won't pay for the test. Then we go on to the need for further testing, and I agree with the earlier comments that MRI has a big future. I think CT angiography has a future. I think nuclear testing has a future. Exactly where they're going to fit in has to be defined. I found the discussions about cost effectiveness very, very interesting, and just to kind of pull it all together, I think we're all in the same team. And Dr. Callister actually should be joining us up here on the panel because he's one of the leaders of this team whose data has shown us how dramatically the knowledge about coronary calcium can predict subsequent outcomes. But in pulling it all together, I do think it does come back to this, what is going to be the effectiveness of finding the early disease? And if this new organization is right, then maybe the assumption that we will be causing a 30% reduction in mortality will actually be wrong. And in the future, perhaps we will be reducing that mortality by not 30, not 35, maybe 40%, maybe 50%, maybe even farther, at which time then we'll have a marked difference in these cost-effective analyses, as was so nicely pointed out by Dr. Taylor.
Thank you very much. Last few seconds of the meeting, I'd like to go back to Dr. Shaw and ask her if you had a wish for a screening test to start for the bottom of the pyramid, what would that test be, and how much that would cost?
Well, the goal would be is that you would want a test which was, it would be as effective as it could be, but it would be optimally as inexpensive as it could be. Paralleling other test costs, it would be at a minimum, now it depends on your perspective, but from a societal perspective, it would be $100 or less.
Less than $100.
In some of the cases, when you think about MR applied to that 40 million people, that would cost prohibitive, in large part because of the amount of induced medications and procedures that could follow that. But certainly I think calcium screening is in that range. We need a lot more data. Some of the laboratory markers are in that range, and that would be a very effective place to start.
Great, thank you. Well, I initially at the beginning of this meeting, I mentioned to you, I gave you a quick report of how many patents are out there on polypill. There were about, last time when I counted, it was about 130 patents on polypill. Pills that are aggregated to each other. My anticipation, and this has been a lot of brainstorming, that once we start this, now currently you have only statin, and on the very top of the pyramid you have drug-eluting stent. Dr. Soroy showed you how he exercised drug-eluting stent and his patients were doing very well. If this era rapidly developed, and as the way I see it, there are actually every day, every week, Tuesday, if you get on patent database, you'll see about 30 to 40 new patents related to atherosclerosis. And I'm amazed to see more than 50% of them are polypill. And this is the wave that I anticipate is happening. And we are scientists in the academia, but the ones who are actually leading and pushing everything is industry, and the money is driving us towards polypill. There is a reason for that, because these drugs, if you accumulate them, the magnitude of effect, Dr. Berman, will be more than 30%. We're going to see that. Now, you've seen Steve Nissen's data with injection. You've seen new data from Alan Fogelman and Naghavi, and recently from P.K. Shah's group, that we are having oral HDL therapy, basically, which would be much cheaper than injection, and will give a far greater effect than statin therapy. So that's where we can really see the vision of putting America in shape is based on what we are building. Now, we have two parallel efforts with AHA's leadership and collaboration with others. One is at the CT level. I look forward to getting a chance to updating you while you're presenting about the detectiveness or ability to detect this, and that is to image vulnerable patient, not just vulnerable plaque. And there are a long list. You will see a few presentations during this city that you can add to the predictive value or diagnostic value of the CT. You have much more information than an average calcium score that you're collecting, and we are not using this information. And if we put them in proper model, we will be able to increase what you're actually doing right now, what you're paying for those data. You take the radiation already. The next level, which Dr. Moreno will be talking about this tomorrow, it's what we call Ultimate IVUS. It's a project, again, with the same nature. With IVUS, you collect so much data. A lot of those data are not being used. Patrick Saroy showed you some of the wavelength analysis, but we, for example, injected microbubbles in the IVUS, and we've seen an enormous enhancement with injection microbubble and vasovasorum imaging. Now, what is vasovasorum? Here's the man who's going to present it the next few days, and Dr. Fuster really inspired everybody in this field that maybe vasovasorum imaging is better than macrophage imaging. So the bottom line is, our already available techniques. We're not creating thermography. I put the first catheter in rabbit 5 years ago, thermal detection, and that was where my exposure to the field was. Now today, after 5 years, my dream of thermography being one single test of screening did not come true, because simply these vasovasorums of Dr. Moreno are washing those temperature out as easily as you can think they can be created by macrophages, and this is one of the hypotheses. The bottom line is, we have IVUS already in our hand. How can we empower it? Get more than IVUS. We're paying for it anyway. We have CT in our hand. What can we do to increase the power of CT? The bottom of the pyramid is the mystery, and I've been starting working with P.K. Shah, and hopefully soon with your group and others, that how can we find a biomarker that would be a risk marker, not a risk factor, because we know that there are so many risk factors that we're not aware of. Now, with proteomics, we might find 50 more. We will find chips that are going to be sold out everywhere, and they do all sort of proteomics. But is that really the way to go? Again, back to analogy of hypertension. I think it's not. We're going to look for the cough test. We're going to have to look for that test that would be less than $100. With that, I'd like to thank everybody that participated in this meeting, and look forward to having the next meeting at AHA, American Heart Association. Between the SHAPE committee, we'll have a small group meeting. We will invite our faculty for a trip to Houston, hopefully at a time that is not too hot, and we will be reporting that as a supplement to Circulation Journal. Thank you very much.